right? So this is where I'll finally get to anterior deltoid. Something about it, I don't know why, I like sitting at the head of the table and just with my fingers walking up and then lifting into the clavicle and into almost like the side of the acromion where all those deltoid fibers are, and seeing if anything jumps out at me. Maybe interlace your fingers like so. The reason I do that is now the only muscles they're using is their interossei in their hands holding, and their abductors and adductors holding, I guess adductors, holding their fingers together, and now their shoulders are so relaxed, and they don't have to worry about holding their shoulders up because their hands are here, now they have to hold their shoulders, or be able to do this and then they round and arch their neck. We want here because that helps the shoulders drop back and we put them in a good position to treat. So just gonna take note of any of those anterior deltoid fibers going up into the clavicle like so. And then the big thing is with my thumb, feeling for the deltoid tuberosity and nudging into that. Not only is anterior deltoid going to be a culprit when we have weak Super Mario Punch muscle test, but also coracobrachialis. So I'm going to go into and just check the side of the coracoid process, feeling for short head of bicep and coracobrachialis, and then I might walk my fingers down along the anterior humerus and feel for the insertion of coracobrachialis and kind of press it in and maybe a little inferior, like right there. We got a spot. Just nudge and work that out. Same thing, so you can see on this side, lifting up with fingertips. Trying to keep your fingers flat, you know, don't poke too hard if you can avoid it. Try to keep your fingertips flat and lift up into the clavicle. That's where I'm feeling the most tone. And then walking my way along. I could hypothetically walk all the way along the acromion into the back of the spine, the scapula, and get anterior, middle, and rear deltoid. With my thumb falling down to that deltoid tubercle, feeling some spiciness right in here. Oh yeah, boink, boink, boink. Nudge, nudge, hold, move around a little bit, like I'm just searching in and out, feeling for what fiber I really want to go after. Nudge, 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 nudge. And then I might check that coracobrachialis, so I'm going after the coracoid process. Fine, I'm a chiropractor, I swear I can find it. There we go. Second. And then feeling for the coracobrachialis inserting on the anterior humerus there. Alright, finally into the cervical spine and the neck. So, I always like to start with just flat duckbill grips on the upper traps. I don't know why, just squeezing along here, just feels good, feels like a good home base to start at. Walking my way out to the insertions of trap. Then I might revisit them, maybe oscillate left and right, kind of hooking my thumb underneath and doing the clavicle, acromion, and spine and scapula as I work my way around. And then as I get that upper trap kind of calm down, now I can start going after, in this case, that right supraspinatus. So now my thumb's going straight in to that supraspinous fossa on the scapula, flat thumb, and clearly a point that was really hypertonic and weak that we found earlier. So getting that kind of deep breath from the patient was expected there. Working through it. Yeah. And then we lose it under the acromion, but find where that insertion point of supraspinatus is on the outside and press straight just into it like so and hold. Feels like a big thick tendon kind of on a lateral, slightly anterior aspect of the humerus, of the humeral head. Yep, there we go. Nice and released now. Now I'm going to go after those scalenes because the upper traps are relaxed. So right under the clavicle, getting onto that first rib, I'm pressing kind of deep and in like so to get that anterior scalene insertion, feeling for the middle scalene insertion, and then flipping over the clavicles, and now my thumbs are going straight down into the posterior scalene insertion points on rib 1 and 2. You can also do a really cool trick here where you take your flat thumbs and just press straight in and hold them and just wait. And as your patient relaxes and breathes, you can actually start, I'll try to demo it with like my shoulders and my body, what my thumbs are doing. But as the patient breathes, I'm actually tuning into where I feel the release happening and I'm following it. And then holding there. And you can actually kind of tune in and in real time follow the tension around, almost like where it's going, and then you hit a point where you may move slightly onto a different, just feel, and it'll guide you on where it's going. Okay, so we got all that now. Now I'm going to use my fingers and walk along the TPs. I like to maybe do a little scan with the fingertips on both sides, generally lifting up, right? Because that's the way the fibers are inserting. But then I might isolate to one side where I feel more, I'm kind of walking my fingers up like so, feeling the side of the TPs, lifting up into them, noting anywhere that's really jumping out at me, in this case a lot more on the right than the left at least. Working my way back down, I might press into that scalene now on the rib where I really felt that fiber in the TP that was most toned up. I'll follow that fiber to where it is on the rib specifically. Check the other side, squeeze the SCMs. If the patient's neck is really arched or their SCMs are tight, you can't get a good duckbill, like flat palm grip or finger grip on it, then you can always stand up, lift the patient's head a little bit, and now it should soften their SCMs and you can squeeze them more easily. Keep in mind, upper trap and SCM are innervated by cranial nerves, so your concussion patients or your brain trauma patients or anyone who's dealing with any kind of neurological CNS stuff, SCMs and upper traps are fibers that you want to be checking out because they're cranial nerve innervation. Thank you.
Words are hard.
Try having a newborn, not sleeping. It does wonders to your brain. I'm lifting up into the mastoid process now where that SCM is inserting because I felt on the right side, especially up in here, there was some tenderness. And then I might even go after like C1, C2 TP with my index finger. I'm kind of lifting up into it to get some of those upper scalene insertion points. Then I switch to the back of the occiput and I'm feeling into the suboccipitals. At this point, I'm noticing the right, especially more than the left. So I'm going straight in with my fingertips. I'll try to demo it with this hand while I'm doing it with my right hand. But I'm walking my fingertips deep into those suboccipitals, just pressing straight into them like so. But then I feel for the TP of C1 and I actually push anteriorly like this onto it and just gently hold pressure where I'm like lifting the C1 TP up. Because remember, one of those suboccipital fibers is going from C2SP to the TP of C1. So in case that's going forward, we want to lift it upward, right? Then I might go and feel for that SP of C2 and press into it like so, almost like I'm doing like a right rotation in this case, like motion palpation, but I'm feeling for the tone of that kind of tendon hooking into the SP. Or I might go up to the C1 posterior body and kind of press up and in a little bit to feel the suboccipital fibers there as well. Switching to the left side, checking out all those suboccipitals. Even if the right is where I felt most of it, and the left I didn't really feel much, I'm still gonna do everything I did on the right, I'm gonna do on the left. It's a kind of, I think in some massage practices, they say that that's kind of like a rule of massage, is that you, whatever you do on one side, you always do to the other. That's kind of something I tend to follow when I'm treating patients. If I always do something on one side, I'm gonna do the exact same thing on the other side, just to make sure I'm balancing the body. Granted, there's nothing I have to worry about, like complicating factors or anything. Once we're done, if you do end up doing any kind of jaw work, TMJ, this is where we can start getting into the face and the cranial area. So let me